So, as I say, what I'll present in the next talk is really, I think I've covered very briefly the past, but I think the present and the future is the present is very busy. There are a lot of grey areas that remain uncertain with the increasing number of agents that we have to choose from, and current clinical trials will hopefully answer a number of those areas. And I hope to show you that the future is looking really very exciting, and certainly compared to the acute leukemias where we really have had no new drugs that really make an impact. I'm hoping to show you that really with CLL we have not just one but a choice and a number of agents coming through that really look to transform how we treat and manage CLL. So really in the last talk we've identified we really need more effective treatments, particularly for patients with 17p deletion. Ideally we would like them to be less toxic, as we do know that whilst fludarabine is very effective, it is toxic to normal stem cells and to the normal immune system. Ideally we want treatments to be oral, so we don't need to ask people to come up and sit in day case units for hours on end or come into hospital. And we need to try and get better at identifying who may not be best served by FCR or other chemoimmunotherapy, and to try and more individualised treatment, as we do know that CLL is such a heterogeneous disease. So in this talk I'm going to really run over a number of agents that many of you may have. I know some of you have had at least beyond some of these or have had. So I'm going to start speaking about other chemotherapy drugs and say a little bit about Bendamustine, which thankfully we do have access to in Scotland. I'm going to speak a bit about newer antibodies, other CD20 antibodies, Ofatumumab and Obinutuzumab, and where we use them at the moment. And then we spent a good bit of time in the first talk speaking about the importance and the rise of CLL on the normal B-cell receptor signalling that drives proliferation of normal B cells. CLL cells, we know, harness this, so that's emerged as a key target for newer treatments, and we have 2 drugs now approved by SMC for some indications, which we'll go on to speak about, and then go on to speak about another class of drugs, the BCL2 or anti-apoptotic drugs. The most far developed is the drug Venetoclax, or you may have heard of ABT199. It's the same thing now called Venetoclax, which is coming through trials and looking very exciting. I think it is important, as we've gathered, there are some people from possibly south of the border, near the border, and practice, and we have a different regulatory system to NICE in England. So I'll really sum up to see where we are for access and where we use these drugs, and to summarise our current treatment algorithm. And then I'll say a little bit more about the trials that are running locally using these new agents. So Bendamustine, as I think was touched on earlier, has been around for a long time. It is a chemotherapy drug. Now I have to say this molecular structure, maybe if there are any biochemists in the room, it may mean more to you than to me, but in a nutshell, it works. The structure works in a similar way. Part of it works like fludarabine, and another part also has a bit of the action of chlorambucil or cyclophosphamide. So it works as a bit of a purine analog and alkylating drug. So it might do the same job as fludarabine and cyclophosphamide in one drug. It was approved in 2008 in the US for treatment of CLL on the basis of a trial. It's given intravenously. It's just quite a short infusion over an hour for 2 consecutive days, given every month, usually for 6 cycles. And it has been initially trialled as a single agent. However, increasingly we are using it in combination with rituximab, one of the earlier trials, and it was really being developed as potentially a less toxic treatment to FCR that we could use, particularly in older individuals who may not tolerate fludarabine. So one of the first trials randomised patients to receive either bendamustine or oral chlorambucil. And just looking at length of remission or progression-free survival, it's fairly clear to see that bendamustine significantly improved length of remission compared to chlorambucil. And looking at this and early studies of phase 2, just single-arm trials looking at bendamustine with or without rituximab, it led to the question, could our bendamustine be as efficacious as FCR, but maybe with less toxicities? So that led to a trial looking not just at relapse, but coming up to first-line treatment, a trial, CLL10 trial, recently published this year, the final, come to full publication this year, where a large number of patients, now these patients were relatively good kidney function, fewer other health problems, and no evidence of 17p, were randomised either to standard treatment with FCR or to bendamustine with rituximab, both for 6 cycles, and mainly primary outcome looking to see whether it was equivalent in terms of progression-free survival. And looking at this, unfortunately, looking at the whole population, looking at the curve for bendamustine and rituximab is not terrible, but unfortunately you can see that the curves split here, showing superiority for FCR over bendamustine rituximab. Now, you can ask me, does this mean we shouldn't be using bendamustine rituximab? And the answer is, my opinion is, I think that bendamustine rituximab, and it still has a place, and I'll show you some data to hopefully support that. There were some queries about this trial showing that there were more unmutated patients in the bendamustine rituximab group, so there might have been not an entirely balanced population that could have accounted for some of this. Also, when they split up the data between patients under and over 65 years, we found that patients younger than 65, we saw the separation of the curves in favour of FCR. However, looking at patients over the age of 65 years, the curves actually look pretty similar. So there's no significant difference in progression-free survival in older patients. And we do know from this study that there were significantly fewer instances of significant neutropenia and infection using bendamustine rituximab as compared with FCR. So I think, considering all of this data, I think that my opinion, and is reflected in the Scottish guideline, is that bendamustine rituximab certainly remains a very appropriate treatment option, perhaps for patients who are perhaps just who would feel a little bit unhappy with treating with FCR. I think that bendamustine rituximab remains a very reasonable alternative. This slide really just shows that, really looking at all of this, is looking at the whole population again, showing that really by stage or cytogenetic group, we found that in the whole population, a line and dot to the right is favouring FCR, and to the left bendamustine rituximab. So in the whole population, generally we found the outcome of FCR better. However, in a selected patient group and older individuals, I think bendamustine rituximab does not seem to be all that inferior, and we do need to balance. The last thing we want to do is to give anyone a treatment where we are going to run into problems with prolonged cytopenias. And in our practice, this is obviously looking at first-line treatment, but we are seeing a number of patients who've maybe had FCR, either FC or FCR, who've had fludarabine 5, 6, somewhere between 5 to 10 years ago, who are now relapsing. who may still be pretty young who would think about fludarabine, but we do in clinical practice worry about second treatment with fludarabine, as we tend to see that's when we see an increased incidence of prolonged cytopenias and running, which can obviously lead to problems in itself. So in that setting, we do certainly, in the West, we do use a fair amount of bendamustine and rituximab, perhaps in patients who've had a good long remission from FCR, but then do relapse, and we just think we just don't want to run into problems with bone marrow toxicity. I think bendamustine and rituximab does have a place there. So, but we've got a lot to get through, so I'll move on. Now, we've spoken about rituximab and monoclonal antibody therapy. I just wanted to put this slide up to just say a little bit more about how they work. I've mentioned that they do bind onto the current antibodies we use all bind CD20 on the cell surface, and they either activate something called complement, which then basically, once activated, sticks on and punches big holes in the cell membrane and the cells die. Or the other way that antibody therapies can work is by sticking onto the surface of the cell, and then that flags up the cell to other cells in the immune system that then bind on and release their toxic granules to kill off the cells. So there are two main mechanisms that antibodies can work, and different antibodies can activate more of one or the other pathway. The next antibody that came along on the scene after rituximab was Ofatumumab, which again binds to CD20, but at a different site on the exterior on the CD20 protein than rituximab. It binds a bit closer to the cell membrane, and it's got to stick a little bit better, not fall off as much, and it also is more effective than rituximab at activating this complement side of things. It was initially looked at in patients who were refractory to other standard therapies, fludarabine and Alemtuzumab, which is an antibody to another molecule, CD52, that we don't use so much in CLL. I don't know if some of you may have been treated with Alemtuzumab in the past. It is very immunosuppressive. And it's rare now that we have the newer agents that we use it these days, so I've not really said too much about it. But just to say that we initially looked at Ofatumumab as a single agent in patients who were refractory to all other available therapies at the time, and we found reasonable response rates of around about 50% in what was a very refractory patient group. So it then became licensed on the basis of this study, but was not approved for use in Scotland for this population. However, like all newer therapies, we then bring them up into saying, can they add anything to first-line therapy? And Pete Hillman down in Leeds set up and ran the Complement 1 study, which was a randomised trial looking at patients who are generally older, typical patient group that we see in clinic. Took a large number of patients we felt were not suitable for treatment with fludarabine, either due to age or comorbidities, and treated either with oral chlorambucil alone or chlorambucil in combination with Ofatumumab. And looking at the graph, we could see quite a significant increase in progression-free survival, almost doubling in progression-free survival for the addition of Ofatumumab. And on the basis of this, Ofatumumab has now been approved in Scotland for first-line use for those not suitable for fludarabine. But it's not the only antibody on the scene. There's another antibody called Obinutuzumab, again binds CD20, and compared to Ofatumumab that activates mainly the complement, punches holes in cells, Obinutuzumab is much more effective at attracting other immune cells, so what we call antibody-dependent cytotoxicity. So it works in a different way to, has more of one effect, mechanism of action compared to Ofatumumab and rituximab. And This also is now approved for use in Scotland on the back of a trial, the CLL11 trial, now published a couple of years ago. And in this trial, patients were randomised between 3 treatment groups, either to receive chlorambucil alone or in combination with rituximab or in combination with ofatumumab. And looking just at the overall responses, patients treated with chlorambucil. Now, when we look at trial response criteria, they're quite strict. To have a partial response, we need at least 50% reduction in white cell count and lymph node size. So I'm sure more than we will have seen some response, but to meet trial response criteria, we saw a low level of responses with chlorambucil alone, as we would expect. The dosing of chlorambucil in this trial was slightly different to that, but it was a lower dose and different schedule compared to what we use in UK and Scottish practice. But we would expect few complete responses with chlorambucil. We saw that combining with either antibody improved the response rate, and there was a slight benefit for looking at improvement in response rate for Obinutuzumab compared to rituximab. When we look at progression-free survival, this graph just has the orange line is chlorambucil rituximab, and then this blue line is Obinutuzumab chlorambucil, and this is really showing that Obinutuzumab does seem to be a more effective antibody than rituximab used in combination with chlorambucil. It is in clinical practice, I have to say, I personally have just had one patient treated with Obinutuzumab, and it'd be interesting to hear anyone else who may have received this drug here. We do see with monoclonal antibodies, as many of you know who've had rituximab or other antibodies, we do see infusional reactions more common on the first dose. And we see, because they activate the immune system, we can see all of the symptoms we get when we get flu. So we can get a temperature, muscle aches, shakes and shivers, rigors. And we do know that Obinutuzumab, whilst being a much more effective antibody, we can see with the first dose, we frequently see infusion reactions. So we start at a low dose, and then it's and then the dose is titrated up. We do need to make sure patients are well hydrated, and we would admit patients for the first dose of Obinutuzumab to manage side effects. After the first dose, it tends to be much better tolerated, and we don't see the infusional reactions generally in second and subsequent infusions. This graph is looking at overall survival, and there does also seem to be a benefit with the Obinutuzumab over the chlorambucil alone arm. So on the basis of this trial, Obinutuzumab has also been approved for use in Scotland. So you can see already we have a choice for patients who we would feel reluctant to treat with fludarabine. We could use either antibody, and I think it's going to be some years, and I think it's going to be important that as haematologists working in Scotland, where we have the choice, that we do audit how our patients get on to try to look at how the different antibodies are tolerated, whether in clinical practice we see differences in outcome in our clinical practice. So certainly we'll need to look at that. Now, back to B-cell receptor signalling. You'll be very familiar with this immunoglobulin molecule. I don't want you to be familiar with all of this. This is something I drew myself for my PhD, so I'm very proud of it and wanted to put it in. But what I want you to take is when the B-cell receptor is activated, then there are a lot of proteins that need to work as kind of messengers. If you imagine a parcel chain, if you think back to one of our referendums and looking at the polling station, passing boxes along, that's kind of what happens if the B-cell receptor is activated. There are a lot of proteins that then transmit to another protein to transmit a signal from the outside of the cell down to the cell nucleus to actually get something to happen to the cell. Looking at identifying all of these guys then started to become targets, and a lot of research looked at different targets. I kind of looked at these guys, which worked a bit, but really didn't emerge as the front runner. But looking at this kinase, Bruton's tyrosine kinase, or BTK, and this enzyme down there, protein down there, both have emerged as key targets that we now have drugs to almost specifically bind to and inhibit this growth survival signalling pathway. So the first drug I'll speak about, I don't know if I should speak about Ibrutinib first, as we've had approval for Idelalisib first, but it's next to my slide. So Ibrutinib was one of the first drugs that has come through the development pathway and only recently been approved for some indications. Ibrutinib is a very small molecule drug that gets into the cell and specifically binds to the active or site of the BTK enzyme to stop it activating the next proteins in the signalling cascade. It is oral, which is what we want, and it's once a day, which is always good. I've put up some side effects at the moment. We know that it's almost specific to inhibiting B-cell receptor signalling. However, the BTK and similar enzymes are also involved in activating cells like platelets, or cells that we need to stop us bleeding. And we do know that Ibrutinib can and does inhibit platelet function a wee bit. And in the early trials, we did see a number of patients run into problems with bleeding complications, particularly on warfarin. So now, one of the exclusion criteria, we cannot use it in combination with warfarin. There's ongoing debate, and in years to come, we'll learn more about using it with other anticoagulant drugs, with heparin or antiplatelet drugs. It does interact with a number of other drugs that are metabolized by some liver enzymes. So we do need to look at a patient who may be a candidate for Ibrutinib. We need to look through the other medication list and sometimes make a few changes, and certainly advise patients if their GP wants to start any new antibiotics or new medications to let us know, to run through to make sure there are no interactions that would affect the blood levels of the drug. Whilst it doesn't suppress the normal immune system to the extent of fludarabine, it's not without some side effects. We can see diarrhea, which tends to be, in our clinical practice, tends to be very minor, very transient within the first week or two. It can cause a rash, which can be more severe, but I've not seen that with Ibrutinib. We can sometimes see that it can affect the cardiac conduction, so it can cause arrhythmias in about between 5 to 10% of patients. I've not come across that yet, but it is well reported. So there are a number of things that we do need to look out for with it. So I'm not selling it very well, am I? I'm going to show you some evidence to show you it's a very good thing, though. So in the first clinical trials, when patients were starting on different doses of Ibrutinib to find the best dose, and one of the first things that was observed in patients starting Ibrutinib was that actually the white blood cell count shot up. Now, in the first few trials, some patients were actually taken off treatment because, despite all of the lab evidence showing that it killed CLL cells, obviously if you start somebody on a new drug and their white cell count shoots up, you might think, oh my goodness, this is doing the opposite of what we thought in the lab. But actually, whilst that was happening, patients' lymph node sizes were coming down. We'd see lymph nodes shrinking away and spleens and livers coming down. And what we now know is that we know that the BTK enzyme also is important in CLL cells being able to migrate and access into the lymph nodes. So by blocking that, you actually stop the CLL cells being able to get into the protective lymph node and bone marrow environment. And that causes this initial spike up. So it's actually showing that the drug's doing lots of things we want it to do, and then over time, as these cells are shifted out of the protective lymph nodes, then they don't get the survival signals they need, and the white cell count does come down after a few months. But the effect on lymph node size can be really dramatic within a week or two. And looking at all patients, you can see this looks a very much better progression-free and overall survival curve, and these are relapsed patients. So this is an awful lot better. Overall response rates, being very stringent about it, are about 70%, but if you take into account the fact that lymphocyte count goes up even while patients are responding, then the overall response rate's over 90%. And that is regardless of cytogenetic group. So initially patients with 17p deletions or mutations will respond as well as any other patient. Looking over time, there is a slightly higher relapse rate in patients who do have a 17p deletion when it's used alone, but this curve is still so much better than the graph I showed you way back at the beginning that really went down like this. And so it certainly is a great improvement on treatments we've had to date. And an update just presented at ASH a couple of years ago is actually they looked at about 150 patients with 17p deletion and really found a much more favourable and progression-free survival curve, and looked at about 13 months. The majority of patients remained on treatment. That led to a phase 3 trial where it was like randomised trials to compare any new treatment against standard of care to be able to say this then should become the new standard of care. So that led to the Resonate trial, and where patients with relapsed CLL were randomised either to Ofatumumab, which is felt to be the standard of care at the time the trial was set up, or oral Ibrutinib. There was allowance for some crossover to Ibrutinib for patients progressing on Ofatumumab as well. And the trial, when published now a couple of years ago, really you can see that there is such a marked improvement in progression-free survival in patients on Ibrutinib. I'll not go through and again, the response was independent of patient cytogenetic groups or number of prior therapies. And again, you can see the curves, even with the crossover, were separated. Looking at overall survival, we're coming out clearly in favour of Ibrutinib. So now, on the basis of this trial, the SMC have, rather controversially, it was submitted for use either for patients relapsed patients not suitable for chemoimmunotherapy, or patients with 17p deletion, and it has recently just been approved for patients with 17p deletion, which is not ideally what we would have hoped to have had it approved for. However, we still can access Ibrutinib through individual patient treatment request processes for other patients who we feel would particularly benefit from Ibrutinib. But thankfully, it's not the only B-cell receptor inhibitor on the market. Idelalisib targets another protein in that signalling pathway, PI3 kinase, which is pretty specifically expressed just in lymphocytes. And again, this the target here isn't just downstream of the B-cell receptor, but also downstream of signalling pathways that are involved in CLL cell migration. So when we treat patients with Idelalisib, again, we see the marked increase in white cell count as the cells come out or can't get into the lymph nodes at the same time that the lymph nodes are coming down in size. And on the basis of the early trials, their phase 3 trial, rather than Ofatumumab, they used Rituximab as a comparator. Rituximab alone, actually it was a placebo controlled trial. So patients within the study that's led to approval of Idelalisib either received, and this is an important difference, in the pivotal trial patients received placebo and Rituximab or Idelalisib in combination with rituximab. There's ongoing debate as to how much the rituximab adds to idelalisib, and I think that will be answered in time, and again it will be something to audit in our clinical practice. But within the trial, all patients received rituximab either with placebo or the active idelalisib, and rituximab was given for 6 months, and then idelalisib continued for as long as benefit. Again, the same as ibrutinib, although very effective treatment. Unfortunately, it's not given as a course of treatment. We do know that they do need to be taken as continuous treatments. As patients who stop treatment, often we see that the disease comes back really within quite a short period of time after stopping. So unlike FCR, which is over in 6 months, the newer treatments, they're continued treatments. Looking at this trial, again, looking at the progression-free survival, there's really a marked separation of the curves in favour of idelalisib plus rituximab. And again, that was independent of mutational status or cytogenetic group. So on the basis of that, we now have SMC approval for, and we have had for about 18 months, for using idelalisib for patients who have been previously treated and we feel at relapse are not suitable for chemoimmunotherapy. And we do treat patients who we feel that may not tolerate bendamustine, and we can use it in patients who have more significant bone marrow failure, as it is not as toxic to the bone marrow. And we also have approval for use in 17p deletion. Now, when idelalisib, I've not said anything about side effects, very briefly. Some of the side effects are similar to ibrutinib. You can see rash, which can be marked. We do need to monitor liver function, as we can see a hepatitis, which is thought to be due to effects on the normal immune system. And we can also see diarrhea, and unlike ibrutinib, where it tends to be early and transient, we can see that with idelalisib as well. However, there is a well-recognised development of diarrhea or actual colitis, more inflammation of the bowel that can occur after several months on treatment. And we have had to, in our local practice, we have had to stop drug for either hepatitis or patients developing later onset colitis, and that can start really after several months, 8 months, up to a year on treatment. So certainly in this group of patients who don't tolerate idelalisib, we certainly have applied for approval to use ibrutinib in that setting. I think it's very encouraging that we do have 2 drugs that target the same similar pathway, because we do have choice. Say somebody on warfarin or on an anticoagulant, we would favour idelalisib. However, somebody perhaps with a history of colitis, we might favour ibrutinib. So it's always good to have choice, and what suits one patient may not suit another. Another thing that's come through, idelalisib has been studied in a number of first-line trials, including the Rialto study, did include a randomisation to idelalisib or placebo. However, we did find in first-line trials that there was an increased incidence of infections, particularly respiratory infections, and that led to a warning and stopping first-line trials of idelalisib. Now we are advised that we should be using prophylaxis against PCP pneumonia, so Septrin or pentamidine along with idelalisib, and we also need to look for viral reactivation. So we now know idelalisib does suppress the normal immune system to a greater extent than we initially thought. That said, we've not stopped all of our patients. We do have a number of patients who remain well and remain very well on idelalisib, and we have just ensured that we do have appropriate prophylaxis. More recently, it has been again accepted for first-line use if there is not another therapy, but in Scotland we now do have Ibrutinib for first-line therapy. So my feeling is probably for patients with 17p deletion, we will be using Ibrutinib. But again, we have choice if we have a patient who would not be suitable for Ibrutinib. I will have to move on with time, and I wanted to say a little bit about ABT199 or Venetoclax, which you may have heard about coming through the research pipeline. And this again works in a different way. So this is, forget the B-cell receptor signaling pathway at the moment. This works in a completely different cell death pathway. Within all of our cells, we have a number of proteins with all of these names up here, but basically this group of proteins want to join together and trigger cell death. And normally within our cells we have these proteins up here that normally bind to them and inactivate them so that our cells don't die. ABT199, now called Venetoclax, is a small molecule that is meant to be this pink triangle in here that fits in and binds to the anti-cell death proteins that then frees up these proteins to then trigger cell death in a different way, and that's not dependent on p53 function. Now, the initial trial looking at phase 1, really looking at trying to look at dose, the safe and optimal dose, looked at over 100 patients, and a number of patients were started on really quite high doses of drug, and the majority of patients in the trial had very adverse cytogenetics or had a large number of previous therapies. And looking at the effect of really any starting dose, you could see this is looking at the lymphocyte count and lymph node size on treatment, and that's a 50% reduction there. And you can see the vast majority of patients had really marked reductions in their lymphocyte count and lymph node sizes. Unfortunately, it was almost too effective with the first group of patients treated, and actually we saw a lot of tumour lysis, where we see massive release of intracellular proteins which can lead to kidney failure, and there was actually a small number of deaths in the first trials before this was recognised, and that has led to a significant change in the way Venetoclax is used in trials now, with patients starting on a very small dose and gradually dose escalating and receiving very aggressive therapy to maintain hydration and protect the kidneys against the effects of the drug. Within Scotland at the moment, it remains in clinical trial. It's not anywhere near being submitted to SMC, but there are a number of trials looking at Venetoclax, and there are similar drugs coming through in development that will also soon enter trial. So where are we with these drugs? So Bendamustine. Bendamustine is accepted for first-line use in patients in whom fludarabine-based therapy is not appropriate. Certainly in our practice we do sometimes use it, as I said, second line in combination with rituximab for patients that we just don't feel would tolerate a second full course of fludarabine. In terms of patients who older patients we don't feel would be fit for a purine analogue approach, we do have both Obinutuzumab and Ofatumumab approved in combination with chlorambucil, and as I said, because we have a choice, it's going to be very important that we audit our clinical experience to really learn what we should be using when there is really a choice for the same indication. Idelalisib is approved, as I said, for relapse, unsuitable for chemoimmunotherapy, and first line in patients with 17p deletion, but only now with the caution and concern about an infection risk. Now that we do have the recent approval of Ibrutinib, I think we are going to see a lot more Ibrutinib being used here, but again, there is a choice, and Venetoclax, as I say, is coming through. And when we're deciding on the most appropriate treatment, obviously we need to take into account patient age and fitness. Kidney function, particularly important when we're using fludarabine, and we are trying to look at assessment of fitness or other health issues to try and give us an idea as to how patients would cope with chemotherapy. As I say, looking at genetic profile, looking to see do we have evidence of the P53 mutation, as that influences therapy, and obviously we need to think, is this first line or relapse? We can, in patients who have had a very durable response to chemoimmunotherapy, but that being FCR would be really 5 years plus, then we could retreat with chemoimmunotherapy. For patients with a shorter remission, then we do have the options of the newer drugs. I've not said much about allogeneic transplant. It used to be that we would consider an allogeneic transplant in patients. It remains, unfortunately, an option for the minority of patients, given the average age of diagnosis being above that we can safely go on to allogeneic transplant. However, for younger patients, it tend to be really below the age of around about 60, who either were refractory to fludarabine or had an early relapse within 1 or 2 years, we would refer and start to look at a transplant option. Now, with the advent of the novel agents, it remains a grey area as to if you potentially could go into a transplant if you relapse early after fludarabine, whether you're best served by a transplant or a novel agent. But with the increasing number of novel agents and the very encouraging results we have with them, we are tending now to save transplant for failure of one novel agent, now that we do have a number of different novel agents that we could then use for patients who relapse on a novel agent. But I'll not say too much about transplant. Just wanted to summarise what we do have agreed in our first-line treatment algorithm. So currently, for patients with no 17p deletion, generally under 70 years, we would still, FCR remains our standard of care. However, we do have the option to use Rituximab and Bendamustine either for younger patients who perhaps have hypertension, diabetes, renal impairment, or for older patients who are otherwise generally fit. And then we do have the choice for patients with more significant comorbidities. And with 17p deletion, recently SMC have approved Ibrutinib for this indication, and we also have the option of Rituximab Idelalisib. We obviously want to be trying to really answer. There are a number of grey areas, as we've touched on, and hopefully some of these will be answered by current clinical trials. I've really just put up there are a number of trials which you can find on the CLL Support Association website. I think has the link to the full table. I've just put up trials that I'm involved in running locally, and one of the trials that's recruiting very well is FLAIR, which is a first-line comparison for patients who we would consider FCR for, and it's ran a 1-to-1 randomisation between FCR and Ibrutinib and Rituximab, and the Ibrutinib is continuous. Again, Rituximab is for 6 months of treatment. There is the option within that trial. We are looking at minimal residual disease, and if patients have persistent MRD negative status, we can stop Ibrutinib within this study, and that will be very interesting to see how that goes. For patients not fit for FCR, we still have the Rialto study open, which is comparing Ofatumumab in combination with chlorambucil and Bendamustine. There was an Idelalisib randomisation in that, which has now come out. An exciting trial I've just opened and actually consented my first patient this morning to the Clarity study, which is open to open to patients who relapse at any point following chemoimmunotherapy, and that is looking at a 2-month, it's a phase 2 study, it's not randomised, looking at a run-in period of 2 months of Ibrutinib only, and then adding Venetoclax as a dose escalation over the next couple of months. This is to tell me I've gone on for too long. And this trial's in follow-up. So I'll just run through that. So, as I've had my warning bell, I will conclude. So I think clearly we have a significant increase in the number of available treatments than we had 10 years ago, and our current challenges, there are a number of areas in our current challenges to work out optimum combination, ideally working to find, can we use novel agents in combination, can that lead to cure, can we get the level of disease down to the level that we can stop treatment and it won't come back. Certainly have a number of new questions that will hopefully be addressed by trials, and certainly I think that I hope I've shown you that really that as patients living with CLL, certainly we have a good number of options, and it certainly and that for patients particularly with what have been considered to and have been poor prognostic markers, that we've really significantly improved the outlook. There's obviously a lot more to do.